catch up with the discussion, but for the interest of time, I think it's best for us to start. So again, good day, everyone. I hope you are safe, wherever you are in the world. Happy Thanksgiving and Black Friday for those who are celebrating. To those new in the SIHI network, welcome, welcome. We are absolutely delighted to have you on board. SIHI, which we pronounce it as SIHI, stands for Social Innovation and Health Initiative. We were launched in 2004 and dream of a better and healthier world through social innovation. We do this through research, capacity building, and advocacy. You'll get to know more about SIHI in just a bit. And also welcome to those who are already part of the network, our various implementing partners, the university-based SIHI hubs, and our contributing partners. Thanks for finding the time to join us. I am Arthur Kekopo, co-leading the SIHI Network Secretariat with Dr. Meredith Labarda. And on behalf of the Secretariat, I will be hosting and moderating this session. Today is our fourth run. This is our fourth edition of the SIHI Talks. And SIHI Talks is a series of monthly webinars that aims to provide a platform for potential and current partners to connect with each other and find opportunities to collaborate. In this edition, we are privileged to have with us today Dr. Elena De Nova, I hope I pronounced it right, CEO and co-founder of Feebris, a company whose AI-powered platform enables carers and health workers to assess health risks in the community and enable early detection of deterioration. Joining her in the panel are our colleagues from SIHI India, the Derby Foundation, represented by Dr. Lakshmi Jagan, and SIHI South Africa, the Bertha Foundation, represented by Katusha De Villiers. So, all right, without further ado, let us start the program with an opening remarks from Dr. Beatriz Alpaap, co-founder and lead of the SIHI. Dr. Beatriz.
Hi, everyone. Well, welcome. I think it's a nice opportunity and a privilege to open once again this SIHI talk, and I'm very pleased to actually welcome Elena, who has been involved in SIHI from the beginning in 2014, and Elena was one of the first researchers conducting the case studies that we did together with the Bertha Center. So it'll be exciting to hear what Elena has to say, and a long journey then on being an innovator herself, and then establishing her own enterprise, and now having got a good run and able and welcoming any opportunity for collaboration with SIHI, which allows us then to think once more about opportunities to discuss and collaborate with private sectors. So this all SIHI talk will be quite interesting in terms of looking a little bit beyond what we have done so far and see, how can we enrich our partnerships and make the world SIHI network stronger and the hubs even more sustainable. Over to you, Art. Thank you.
Thank you, Dr. Beatriz. So before we begin, allow me to give you a brief overview of the SIHI network. Sir, can you flash the screen, please? So as I said earlier on, we pronounce SIHI as SIHI. And then next slide, please. So we know that the SIHI network is supported by the PDR, the Special Program for Research and Training in Tropical Diseases, co-sponsored by UNDP, UNICEF, and the World Bank, and the WHO. And PDR receives additional funding from SIDA, the Swedish International Development Cooperation Agency, to support the SIHI work. We all know that globally that the challenges continue to persist in terms of access to quality essential health services. So we hope that SIHI, the Social Innovation in Health, to promote the SIHI as a new lens or to promote inclusive innovations, development of solutions that meet the needs of end users through a multi-stakeholder community engaged process. Um, Elena is no longer, Dr. Elena is no longer stranger to the SIHI. So we're just happy to share with you, Dr. Elena, that we already have 13 research hubs globally. So we have the research hubs are university-based research hub that advance innovation in health in the country systems, and regions through research and training. We also have implementing partners that help us implement and organize SIHI activities, and then several contributing partners that help us broaden our network of support for SIHI-related activities. As you can see in the next slide, we are advocating for multi-stakeholder approaches, and the research institution-based hubs partners with several organizations and groups, such as the academia, the social innovators, the communities, the private health implementers, government, and private sector groups. So I think this is the opportune time to look at that perspective, collaborating with a private sector group. We introduced various approaches, such as research and capacity building for research, storytelling and raising awareness, convening and building communities, as well as institutionalization. And finally, the next slides, maybe these are some of the areas that we can think about later on how we can potentially collaborate, how the SIHI hubs and perhaps Feebris can work on a collaborative projects in the future. So these are some of the past, ongoing, and upcoming projects of the SIHI hubs. Yeah, I think that's it. So now I think we are ready to and excited to hear your presentation, Dr. Elena Naidino.
Thank you very much. And it's an absolute pleasure to be back, actually. As Beatrice was saying, I was part of the SIHI community in the very early days when it was being set up in 2014. Probably the thing that speaks the most about this is that was the time when we were discussing, should it be called SIHI or SIHI, or all the different variations of the pronunciation. I'm glad that we found a solution by now. But I had an absolutely amazing time working on kind of the initial stages of ideating and then putting together the first set of research that we conducted. Specifically, I was responsible for the innovators in India, covering 5 very inspiring and very different innovations that were making a difference at the time in the health system from very different perspectives. And as Beatrice mentioned, I've been on my own personal innovator journey, which is what I would like to share with you over the next 10 to 15 minutes. And I'm very, very excited about the conversation afterwards and exploring various opportunities for collaboration. Let me just go ahead and share my screen quickly. I hope you can see my slides.
Yep.
Great. So I'm currently the CEO and co-founder of a company called Feebris. We operate in the UK, particularly over the pandemic. We have been working very closely with the National Health System, and I'll give you some kind of specific stories around this over the next few slides. But before I jump into this, I just wanted to share the origin story, which also gets connected to SIHI on different points of the journey. So I was actually working at the WHO and the medical device group back in 2014, focusing on childhood pneumonia. And it was actually the first time for me to realize that a perfectly treatable disease, pneumonia, is the #1 killer of children under 5. And unfortunately, that still continues to be the statistic across the world. I became obsessed with that problem, trying to figure out why that's the case and how could we possibly solve this. And then ended up deciding that I'm very passionate about developing solutions. So I went to Oxford and did a PhD specifically on this, which I'll tell you about in a second. But as I mentioned, this problem perseveres now 8 years later. We're still looking at the same statistics. It's still a very horrible reality for very young children, but it's also very much one of the biggest problems that older people around the world face, especially when it comes to preventable hospitalizations. So my personal journey then took me to Oxford and the biomedical engineering group there, where I focused on developing machine learning and AI algorithms that detect pneumonia in community environments. What was very important for me at the time is that I don't do my research in abstraction and just focus on developing algorithms in Oxford's labs, but I very much spend enough time with the users, the patients, and the children that are suffering from this problem. So all of my field work was in India, in Mumbai in particular, working in urban slums, and first and foremost, learning about the challenges that specifically parents and children face, but also the community healthcare workers that see these children on a daily basis face. And in this environment, I started thinking about how can we leverage point of care devices that are becoming more and more prolific around the world, but couple them with intelligence that AI algorithms and machine learning algorithms are known to bring to healthcare, so that we can automate a lot of the early detection of disease. And my whole thesis was focused on this, and really the big kind of discovery that resulted from it was that we can automate the interpretation of stethoscope recordings alongside a couple of vital signs to provide an early indication of whether or not a child has pneumonia. And I ended up validating this finding against a very sizable data set that also included X-ray and blood tests as the gold standard. So by that point, I was very encouraged that there is a lot of innovation we can do in this space, and the problem could have technical solutions, but that's always just one small piece of the puzzle. And there is a lot more that comes with really bringing innovation to patients, but also the sustainability of that innovation. So I personally then decided to focus on setting up a business or a social enterprise that focuses on really developing these types of technologies and bringing them to patients around the world. And we were very lucky in the early days of the company to be able to operate both in India and in the UK. Particularly in India, we continued growing our impact with children. The last study that we had there included 6,000 children, and show that we can greatly accelerate access to diagnosis and improve the capabilities of community healthcare workers. And then very unfortunately, the pandemic happened, which for us meant that we couldn't continue with our community activities, particularly in a country that we didn't live in, given all the lockdowns. And at the same time, it presented a great opportunity for us to start helping the national health system in the UK, where we're based, particularly focusing on older adults in care and nursing homes. And the last 3 years have really been a big journey of transformation, figuring out exactly how we can help do things differently, and particularly how can we help alleviate the pressure that health systems are facing at the moment, particularly when it comes to the lack of doctors and nurses and healthcare resources in general. So a little bit more detail around what is it that we actually do. So we focus on developing a technology platform that enables non-clinical workers to play a significant part in the early detection of disease. Specifically, if you think about what happens when you go to the doctor, I mean, most of you on the call are probably doctors already. So the different stages that an evaluation goes through, you have the information gathering at the start, then the triage or the risk assessment, and eventually the diagnosis and treatment. What we're focused on is how can we build a decision support tool and an AI-guided platform that enables non-clinicians to take care of the first two chunks of that experience, so that we can free up more clinical time for doctors to focus on the diagnosis and the treatment and the caring for patients. And very practically, what this looks like is it's a software platform. It has a mobile application that includes a number of algorithms in it that's designed to guide the user and help them make decisions along the way. We don't manufacture hardware. We work with existing medical sensors. We pair with them wirelessly so that we can take the data directly from the sensor in real time, analyze it, and then provide the user with guidance and advice. And as I mentioned, we have been doing this over the last 4 years now across very different settings. The work in India was focused on pediatrics. Our work in the UK has focused mostly on older adults, but more generally, the top 5% of the highest risk patient groups. What this looks like in practice is whenever we deploy our technology in any setting, it comes as a kit, which is what you're seeing in the bottom left corner. It includes a number of sensors in it, and it all pairs with a mobile application that's designed to guide the user. We also have a clinical portal that's designed for clinicians to risk stratify their patients and make remote decisions in the back of the data that we capture. And the mobile app is really the core of what we do. It very much emulates a clinical exam with a lot of decision support along the way, so that even if a user, for example, doesn't know how to use a stethoscope, with the help of our application, they would receive guidance on where to place it. In real time, we'll analyze the data to tell them, are we capturing clear respiration, or do you need to reposition the sensor? And then at the end of the multiple measurements that they conduct, we give them a risk stratified evaluation of anything that we've detected that's abnormal, and also a recommendation of what the most appropriate next step of referral is. The reason why I mention AI and machine learning on a couple of occasions in this conversation is because the quality of information in community settings is absolutely critical when we have to make decisions, often by non-clinical workers or users, that inform what happens next. So practically what that means for us is we've developed algorithms that first and foremost guarantee the quality of the information being captured by guiding the user, but then also have the capabilities of extracting additional symptoms from these different data sets and signals, so that we can aggregate all of them into a risk score and give an appropriate recommendation. And to give you some very kind of practical case studies and stories. As I mentioned, the work in India was focused on pediatrics and pneumonia in particular, alongside a number of other respiratory conditions. Our users were community healthcare workers that were using the kit alongside their daily visits. And whenever they were worried about a child, they would conduct an assessment or an exam with our technology, which depending on kind of the different signs that were shown, would, for example, prompt them to also auscultate the child with a digital stethoscope, take their oxygen saturation, etc., and give them a recommendation on whether the child should be referred to the local doctor or taken to the hospital, depending on the severity of the situation. Some of the most impactful metrics that we were able to quantify in this very sizable deployment was the acceleration to diagnosis, which we saw a 5x improvement in, as well as a lot of savings for families that otherwise have to cover the cost of going to a couple of doctors until they actually make the tough decision of taking the child to the hospital. We saw that we can streamline that pathway quite significantly and save a lot of money for families. And overall, we actually demonstrated a 13x return on investment for the health system, which we have been in the process of publishing. And it is something that's coming out in a publication very soon. A very different story, but actually with a lot of similarities, is the work we have been doing in care homes in the UK with older adults or older patients, where our users are carers. So again, non-clinically trained users that interact with the patients on a daily basis to help them with their care needs. With our technology, they're able to couple this with an evaluation so that they can more proactively identify where patients are deteriorating. And these patient groups in particular suffer from many comorbidities, on average about 5, and they're often in and out of hospital. So on average, that happens to them 6 times per year. So even one of those exacerbations and hospitalizations being prevented results in significant patient quality of life improvements, but also significant money being saved for the health system. So here we've been able to demonstrate that we can do that at scale, working with thousands of patients and evidencing that we can reduce the hospitalizations by as much as 35%. And this is kind of a summary of a lot of these statistics that I have been talking about. But very importantly, this fits into the larger conversation of return on investment and how can we make our health system sustainable regardless of what setting we operate in. And for us, really, where this journey leads in the future is working with more and more health systems to figure out how we empower more community healthcare workers or patients themselves to be able to be this first precise interaction with the health system so that we can avoid a lot of these complications and hospitalizations that come out if undetected. Great. Well, this is all I have as a presentation today, but as I said, I'm very excited and look forward to the conversation afterwards. And thank you very much for listening to me.
Thank you, Dr. Elena. I really appreciate and this is something new for me as well, engaging non-clinicians in, not just as end users of the technology, but, participate in the development and the design of these technologies, incorporating their inputs so that it can be incorporated in the way they implement their healthcare or the processes that they capture these vital data from the patients, from the communities themselves. So, and one of the things that I also appreciate is the fact that, the networks that you build, the partnership that you have to go through, enabled for us to be able to implement the system, because designing the technology is one thing, but making it work in the community requires a lot of moving parts, and we're interested to know more about it. Maybe just a food for thought for now on how you're able to bring together partners and stakeholders to make it work. But before that, I suppose we will hear from our own SIHI India Hub from Derby Foundation, Dr. Lakshmi Jada. Dr. Lakshmi.
Yeah, thank you. Thank you so much. Elena, it was very nice listening to your presentation. In fact, really impressive and eye-opener of the kind of work you've been doing in India. In fact, I'll quickly share my screen and I'll also run through a formal, just a couple of slides about what we do at Derby. Incidentally, now we are also coming across multiple startups who are leveraging technology for doing mass screening, be it pneumonia, be it multiple diseases, where they have sort of portable kits. Some of them are AI enabled, but they use it for mass screening in rural areas, urban slums. Yeah, so I'll quickly share my screen so that you have an understanding of what we broadly do at Derby. Yeah, are you able to see my screen? Hello?
Yep. Yes.
Yes.
Yeah,
Yes.
sure.
Yes,
we can see the screen.
Yeah, thank you. Yeah, we are a technology business incubator based out of Bangalore. And we are hosted by an academic group called Dayanand Sagar, one of the oldest institutions. The reason we are going in fact deeper into healthcare is primarily the university also has a medical school and allied areas in healthcare. See, we are funded by multiple departments of government. India, typically, most of the incubation facilities are funded by government, and there are multiple programs which the government offers. So what we have done is we have intertwined the government support programs into our own programs. That is, we have a pre-incubation, I'm sorry, I'll just go to this. Yeah, we have a pre-incubation program, incubation, and an acceleration program. So that with each of these programs, we are able to bring in the right support that is given by government. Right now, yeah, so this is the kind of impact we have created in the last, I would say 4 years, supported close to about 150 plus healthcare entrepreneurs. And we have also invested in about 22 entrepreneurs and the partnerships and other things we have done. And this is our advisory board. Predominantly, as you see, we have people cutting across multiple spectrum, starting from investors to entrepreneurs to healthcare professionals we have on our board. And this is primarily what we do as an incubation. Apart from physical space, I think with COVID, the need for a physical space for a startup has also become very, very barely minimal today. So we offer them a lot of clinical support, validation with doctors, clinicians, technology support to build a solution, and also opportunities to implement the solution in the community. So broadly, this is what we do. And as I said, we have 3 programs. One is a pre-incubation program, which is usually a customer discovery program, as we call. Because somebody building in healthcare, I hope you fully appreciate that, has to have a clear understanding of what is the ground reality and what are the expectations from the solution by the clinicians on the ground, clinicians or the end users or the physicians on the ground. So this, we run a 6 months program called Customer Discovery Program, or a pre-incubation program, where we help the innovators understand what is the expectation of the customer. Then the incubation program is a 2 years program for registered companies, where we help them restructure the business model, for refine their solution, and then go to market. Acceleration program is again a 6 months program for startups who are already into revenue making, help them accelerate the business. Yeah, and these are some of the startups, whom we have supported. Just a glimpse of the startup we have supported. As you can see, there are multiple point of care devices, be it detection of cervical cancer, or a hypothyroidism detection, or jaundice detection. No, I think point of care devices have a lot of scope, especially in a country like ours, where there is a lot of developing country like ours, right? Of course, AI, all that would definitely help along with the point of care device. And we very strongly engage with the ecosystem, be it investors, lot of corporates, multinationals, technology companies, and both healthcare companies also, we work with them. And we also work with multiple other hospitals apart from our hospital also. Hospitals also serve as a sounding board for these startups. The clinicians at the hospital help them refine their solution. Sometimes some experiments where we've also done, where we take the problem statement from the hospital, build technology solutions to solve those problems. Yeah, and this is a detail of our portfolio itself. I'll not go into details of all this, where we've invested and what these startups actually do. Yeah.
Thank you, Lakshmi, for sharing your work and the portfolio that you currently have. And probably, Dr. Lina, you may be able to find some collaborative areas where we can probably partner with or collaborate with Derby in some areas where probably improving or probably developing programs for their incubatees, or probably serving as their mentor, probably our expert
Absolutely,
in helping the design.
No, actually, I wanted to understand what is, I think what Elena said was, post-COVID, Elena, have you continuing your engagement with India, or what is the scenario now? I just want to understand.
Yeah, we're trying to restart that effort. It's been a really challenging couple of years, and the NHS, the National Health System here, has gone through some really tough times. So we were just forced to basically focus on trying to help here and solving the problems here. But as countries are normalizing, we're very much keen to restart that effort. So very interested in picking up the conversation and exploring whether there are any opportunities for collaboration.
Fantastic. So you were based out of Mumbai, is it?
Yes, yeah. All of our field work was based out of Mumbai, and we continue to have some presence there. So our clinical lead, for example, is based in Mumbai, and she operates clinically there. So yeah, very much looking for an opportunity to restart that effort.
Thank you, Elena and Lakshmi. We'll continue the conversation later on, but first, let's hear it from the SIHI South Africa Hub. Katusha, the floor is yours.
Yes. Hi, I have also just a very brief presentation, or just like 5 slides. So let me know if you can see my screen.
Yeah, we can see the screen.
Great, thank you. Hi, everybody. My name is Katusha de Villiers, and I am the Health Systems Innovation Lead with the Bertha Center for Social Innovation and Entrepreneurship here at the University of Cape Town in South Africa. And my colleague, Jill Moodley, is also on the call with me and has been a part of the team for 2 years now. We are part of a broader center, and we work within Bertha with an education innovation team, youth development team, innovative finance team, and then a social justice team. And we are a specialized unit that sits within the University of Cape Town's Graduate School of Business. And through our health systems innovation portfolio, we are able to kind of frame our approach to healthcare innovation in Africa for Africans. It is based on an understanding of real health needs and really the idea that social innovation for health is a mechanism through which health systems can move closer to achieving health equity. And one of the biggest value adds and biggest benefits for us sitting at a university is that we are perceived as being a neutral party. So we're really able to bring together cross-disciplinary practitioners, academics, government, private sector, you know, all those folks who maybe wouldn't necessarily sit around a table together. We're able to bring them into the room and work with them to really better understand the different healthcare challenges that we're all confronting. As some of you might know, we hold the dubious distinction of being the most unequal society in the world, and that is very much reflected in our healthcare system as well. This is a picture from a Time magazine article, I think it came out in 2018. It's really striking. On my left, you have a very middle class, upper middle class suburb in Johannesburg, and just across the road, you have the reality for the vast majority of South Africans. So 80% of actually 85% of our population seek healthcare within the public sector, and only around 20% of our doctors work in the public sector. So it's a massively overburdened healthcare system, which is why this topic is so interesting and exciting to talk about the role of the private sector. But that's just a snapshot of the reality in which we work in. And some of our current projects at Bertha, my colleague Jill is doing amazing work with our South African Medical Research Council and our Innovative Finance team, and pulling together a social impact bond. Although she's going to correct me in a minute because we're not supposed to call it a social impact bond anymore. There's a different framing that we should be using. But this is being developed for adolescent and young women in South Africa around sexual and reproductive health. She's also been the lead writer and editor for an Innovative Finance for Health in South Africa report that's going to be published shortly. And then we also have a global surgery education, executive education course in partnership with the Faculty of Health Sciences and Harvard University. It ran for the first time this year. It's going to be running again next year with partners from African CDC as well, which is very exciting. And then also in January, we're going to be publishing our Actionable Insights for Inclusive Health in Africa report that has been sort of funded by the Bayer Foundation and the Schwab Foundation. And through that, the report is actually going to be launched at Davos in January, which is very exciting. And I'll be sure to distribute that so that it can be disseminated across the SIHI network. And then finally, there's sort of breaking news that we have been given funding by the MasterCard Foundation. It's a 10-year grant that we're going to be working on health entrepreneurship in the Western Cape, specifically with the UCT Faculty of Health Sciences. It's going to be sitting with the University of Toronto as secretariat. And then we're going to be collaborating within a number of African universities. So that's just a brief snapshot of the work that we do at Bertha and who we are. Thank you.
Thank you, Katusha, for providing us a very specific examples and concepts on how to engage the private sector in social innovation in Europe. So I think the floor is now open to some discussion with our panelists. So our theme for the panel discussion is about engaging the private sector for social innovation in Europe. So I suppose I will be interested to know what are the key areas that we can engage the private sector in innovating or in health sciences, and probably mindful of the social aspects. What are your thoughts about it?
I'm happy to jump in first. I mean, from my perspective, the short answer is probably alongside the innovation life cycle. I wouldn't say there is one specific area where we should concentrate our efforts. And that's, I'm kind of sharing my perspective, both as someone working in the private sector at the moment, but also being on the other side and working in public health. I think it's very important that we collaborate right from the start, and we are very aligned on what are the needs of the health system and patients, and all the other stakeholders engaged in solving these problems. Way too often the private sector kind of presents itself with a solution too late without having had this initial engagement and building up those bridges right at the start. So I think that's 100% critical. But it's equally critical alongside the life cycle to keep those bonds alive and to ensure that whatever innovation is being developed is actually continuously meeting those needs. From our perspective, that has meant working alongside the health system, but also alongside academic groups, alongside facilitators that are kind of deep experts in things like health economics, etc. And from my SIHI days in 2014, I very much remember trying to map the vibrant actually ecosystem that India has on that front that's currently supporting innovators. So yeah, I'm very hopeful and encouraged that this will only continue to grow.
Thank you, Elena. I think that's a very good segue to Lakshmi. I think we would like, as a university-based incubator, business development and incubator, what do you think are, since most of our research hubs here present are university research-based, what do you think are the lessons can be learned from academic institutions such as the SIHI hubs to effectively engage the private sector?
Yeah, see, there are two things. One is, two buckets. One is private sector engaging should also see some value in the innovation, right? And predominantly, there are two areas where at least we have seen very good way of engaging with the private sector. One is hospitals. Other one, which is also now opening up, is the pharma sector, right? Hospital, I'll give you an instance. See, what we did was we've been working with one of the hospital, which is Bangalore-based hospital, which is predominantly hospital focused on urology and kidney problems, right? So this hospital, what they said we have specific set of problems. And finally, we zeroed in on one problem where they wanted an ultrasound-based vein detection device to be built. And the hospital actually funded us a program where we were able to identify an innovator. Now we've identified an innovator. The doctor is, the hospital is giving them the clinical support to build a solution. Incubator is partially funding. See, this is what is called a venture studio model, where everybody, the hospital, the startup, and the incubator also has a small stake in the company. And it is an interesting model because here the solution we are building, the problem statement is given by a private player. That is one. Interestingly, what is also happening is a lot of pharma companies are now looking at how they can engage with social innovators. Because, for example, we have one startup who's working on a device for diabetic neuropathy detection in the feet, right? So one of the multinational companies based out of India, which has a drug for neuropathy detection or the nerve damage detection, they have got in touch with the startup because they feel that medical devices can also go with the drugs hand in hand. That's the other part. One more thing I want to interestingly also share is India, I think a corporate social responsibility has been made mandatory to all the corporates last 4 or 5 years now. And one of the important elements which is included as a CSR funding or a support is also support to innovations through incubators. So last 2-3 years, what we are doing now is we are talking to corporates. And in fact, see, last year, I think we got close to, fairly good amount of funding from HDFC Bank, where we have supported 4 startups. 2 of them are given money to build a solution. 2 of them have been given money to deploy the solution. For example, there is one startup who has a bracelet to be owned by tribal mothers in rural areas, where they're able to track the vitals of the body and then manage through a digital dashboard. So they have deployed the solution in 50,000 women in tribal areas. So again, corporate social responsibility funding is a big way to get the private players to be interested in what you're doing.
Thank you, Lakshmi. I think there's more and more appreciation of linking researchers or ideas coming from researchers and academics to industry players, so that eventually after that you have a clear market, not just
Exactly.
in addition to market, you have access to grants, you have channels, their channels where you can implement your solutions. I think initially there was like oftentimes from academic perspective, in my experience, researchers are allergic to the private sector because they seem to see private sector as like all about profit and not for social good. But at the end of the day, they have the infrastructure necessary for us to deliver those services that we and the ideas that we have nurtured in the academy. So yeah, I think thank you very much for pointing it out. So
No, one
Katusha, do you
last
have
thing. So I think
Right.
research without commercialization will not add value to the society, right? It's my firm belief.
Yeah, they're just like being stored in the libraries and not being utilized for
Absolutely. Yeah,
for,
sure.
for the betterment of the people.
Yeah.
Anyway, Katusha, do you have any other inputs with the discussion on engaging the private sector effectively?
Yeah, so I think from the South African perspective, we have this fragmented healthcare system, where our National Department of Health is responsible for national health policy, and then the 9 provincial departments have autonomy over service delivery in their respective jurisdictions. And they're also publicly funded healthcare is also not based on need, but determined by each province's relative share of the population. So in many ways, our institutional frameworks are perpetuating inequality within healthcare provision in South Africa rather than addressing it. And while we recognize that healthcare is the province of the state and of government, they set the agenda. And it's clear that they're not able to provide what people need. Not everybody is enjoying the right to health. So perhaps you can't look at the private and the public sectors as being separately. They have an impact on one another. And one way, many ways in which we can address this are also mentioned in the finance report that Jill is in charge of. But we're dominated by a number of very few players. Actually, the Competition Commission in South Africa has just wrapped up a 5-year inquiry on private healthcare in South Africa, and the private hospitals owned by Netcare and Life and Mediclinic groups hold 75% of our private market share, and these are mostly concentrated in Gauteng and KwaZulu-Natal in the Western Cape. So areas in which we can really have an opportunity to make a difference in the private sector would be maybe an investment in the development of mid-fee healthcare clinics that serve middle and low-income South Africans who can't afford this private medical insurance. Or in establishing modular healthcare infrastructure solutions that can then be deployed in remote and underserved regions. And then the other one is really looking at digital healthcare platforms, which can provide access to those South Africans who are situated far from clinics and hospitals. So those are a couple of the areas that I think are ripe, or that we think are ripe for priority investment areas for the private sector, that would then obviously have the knock-on effect of improving healthcare within the public sector.
All right, so thank you very much for our panelists. I'm now opening the floor for some questions or comments from our distinguished panelists. I think I saw Edwin earlier on raise his hand. So maybe would you like to unmute and ask your question?
Okay. Thank you for the time, Art. Can you hear my voice?
Yes.
Okay. Good evening, all the speaker. My name is Edwin. I'm from Indonesia. Yeah, this is my first time to join the SIHI Talk, and it's very inspiring. And from the first presentation, the Elena talked about the artificial intelligence and put Feebris, right? Yes. I have a question since this tool is, I think it's very new and maybe it's less used in developing countries using this kind of technology to diagnose the patient. Then I would like to know about how far the Feebris can do with the IA to treat the patient. And is it possible that it's decide what the medication is need by the patient? So because from your presentation, it's reduce the hospitalization by the patient, and also the community health worker also can help to fastest diagnose. So is it possible that this software can decide what type of the medicine it's used for the patient? Thank you.
Yeah, thank you very much for that question. And it's a very important one when we think about capacity in health systems and the role that technology has to play in that. A very short answer to your question, and then I'll elaborate, is at the moment, no. We don't use the software to kind of make decisions on prescription. And the more detailed answer is, I think it's very important for health systems to go on the journey of gaining trust in these types of technologies. If you show up today and say, I can diagnose X automatically, or and I can prescribe Y drug automatically, you're going to very logically and for a justifiable reason face a lot of pushback by the clinical community, because these are very risky situations, and for any of these technologies to be deployed for that type of purpose, they need to gain a lot of trust. There needs to be a lot of evidence. There needs to be a lot of certification to actually ensure that we can trust them to do that. In our case, we are going on that journey, gradually building up those capabilities. So at the moment, the focus is really empowering people that work in the community to capture the high quality information and then triage the risk. And at the same time, feeding the insights into a clinician. But we are by no means overtaking the decisions that clinicians are making. I can definitely see a world where AI in particular evolves to the point where it can be more suggestive, but I would not want to live in a world where we completely take away kind of the clinical oversight and trust technology to single-handedly make those decisions.
Yes.
And yeah, I'm saying this as a technologist myself. I think it's very important to kind of blend machine and human intelligence to make sure that we're making the best decisions for patients. And of course, it's very challenging living in health systems that are deprived of doctors. So going back, I guess, to the first question of the public and the private sector, we should continue investing in training more doctors and building technologies that maximize their capacity.
Yeah, and I think there are specialty societies, so we should continue to engage them to, be part of that development of an AI-enabled system. But they should provide feedback and continuously provide inputs on design and development of that. All right, so I think, Jillian, you pointed out a very important point. So would you like to articulate it verbally or by unmuting yourself? And then we go to Joe's question to Elena on the hospital at home in the US. All right, Jillian?
Thank you. Yeah, I was just saying part of the work that we're doing at the Bertha Center as well with another team is to advocate for private investors and companies like your investment banks to invest in health and social innovation and make it part of their daily bread and butter. Not only spend it on foundations and CSR, we're trying to say you can make a profit and make an impact as well with the funding that you contribute. Sorry, there's a plane overhead. And yeah, there's so many areas within the healthcare system that private investors can look at. I mean, you can pick the easy, low-hanging fruit like your digital health technologies, or you can look at the deeper structural and systemic issues and see what kind of a long-term investment can you make in those areas. For example, gender inequality in health and contributing to more equity in that instance. And yeah, one of the key issues that we picked up is that all of this is great. The private sector can be like, yes, we're coming on board with an innovation, let's fund it. But if the government doesn't facilitate it, then you're going nowhere. So all of these actors play a key role in the system. And yeah, that was my thinking behind the comment. Thank you.
Thank you, Jillian. So, Elena, maybe would you like to answer Joe's question? So, she's curious about the integration with hospital at home in the US. So, I assume you are working in this space.
Yeah, thank you. And sorry, I just wanted to say how much I agree with Jillian, because sustainability in these solutions is so critical and yet so complicated. It's as we've moved kind of in development over the last 10 years, it's become more and more common for private sector to invest in the early stages of generating these innovations and kind of showing initial traction, but it's so complicated to scale them if we don't have public procurement dedicated to actually financing this at scale. So I couldn't agree more. With regards to the hospital at home question, we are actually working on hospital at home in the UK. In the US, we're not working in that specific use case. We work in rural healthcare, where, interestingly enough, we work with community healthcare workers. So very much the same use case that we've been working with in India. And there it's more about early detection of deterioration rather than patients being discharged from hospital early or preventing kind of the imminent admission. But in the UK, yes, hospital at home is actually a massive program that's growing at the moment. There is about 400 million committed to it over the next 2 years. So there is a huge shift towards really moving patients out of hospital, given the lack of facilities that we all face.
Thank you very much to our panelists. For the interest of time, I think I will have to just ask 2 more questions. So I suppose first, maybe specific questions about areas for collaboration between the SIHI hubs and the private sector, and particularly from Feebris, perhaps, and maybe some practical tips on how to engage the private sector from point of view of the SIHI hubs that are university-based research institutions. I think who would like to go first? But because earlier on, I think Lakshmi already mentioned a very clear work with Feebris, like, engaging them as experts and mentors of their incubators, right?
Yeah. So probably I'll go first. See, one is, I mean, the private players, I think I've already answered that part from my thing. Even when Mr. De Villiers spoke about South Africa, no, I think one potential opportunity I see is where, see, we are not though a lot of startups, entrepreneurs we facilitate have solutions which is research based, we believe in empowering research to reach the community. Maybe between the SIHI hubs, we can see whether we could have cross collaboration to see whether most of the innovators, startups whom we have, entrepreneurs, are looking at implementing the solution in the overseas market. See, we can probably have a separate call to explore, see if there are similar solutions. Maybe we can connect the 2 innovators, connect the 2 entrepreneurs to explore whether there could be a collaboration between the 2 at least, number 1. Number 2, even formally, we could probably at some point of time look at maybe a 6 months program or a 1-year program, 1-year cross-border program on building affordable healthcare solutions. Maybe part of the time they'll be here. We can figure that out, how the structure can be done. I think if you can do a cross-border program, that'll be very good. In fact, what Elena is doing is a standalone cross-border, what she's trying to do, right? If we are able to do it for a cohort, it will be very good. And we can be the partner for India. We can take care of that. Yeah, that's all I had to add.
Thank you, Lakshmi.
Yeah, sure.
Lena or Katusha?
I can very quick add something on the lines of market access. I mean, it's particularly difficult for smaller companies to go to a new country and set up operations. So having some point of entry that helps navigate the complexity of an individual country. Very practically, we currently have quite a few conversations around deployment in Indonesia, and we're struggling to figure out where do we start. So having a point of contact that they can help us just identify what are the things that we should be thinking about is very important. And what I can offer in reverse is we're part of the Department of International Trade in the UK, and they do have country-specific programs. So I'm very happy to reach out and ask them whether that's kind of a more scalable contribution and partnership they can contribute to SIHI.
Thank you, Elena. Katusha?
Oh, goodness. I think there is a real need for the innovators and the entrepreneurs we work with to appreciate that they're not alone in the journey, that there are others, not only within South Africa, but also South-South, who appreciate and understand the difficulty, the blood, sweat, and tears that this journey requires. And I think that kind of peer-to-peer learning and peer almost mentoring, I think, is incredibly valuable. So if there are opportunities for virtual exchanges almost with other SIHI hubs, it would be amazing to be a part of that, or to help facilitate that for the entrepreneurs we engage with.
All right, great final points and closing remarks from our panelists. I think that's really an exciting. We sort of, in a way, from those last remarks from our panelists, sort of zeroed in that peer-to-peer collaborative learning, and that can be explored by the SIHI in collaboration with the other SIHI hubs. And that's really important in bringing in your innovation, not just from the very small scale, but scaling it up in a more broader setting, influencing change and really contributing to the health system strengthening and improving the health outcomes. So I think thank you very much, and a virtual clap to our panelists. Thank you very much for all your insights and amazing and brilliant thoughts about this engaging with the private sector. So I think that's it. So if you don't have any other questions, thank you very much for participating. See you again in the next SIHI Talks, probably in January. Please stand by
Thank
for
you
our
so much.
Thank you.
Thank you.
Bye.
Thank you.
Thank you, Alina.
Thank you for organizing it and for such nice
Thank you.
presentation. Bye.
Bye.
Bye.